Hello, and welcome to the Director's Desk, where we explore groundbreaking work of the National Institutes of Health and the people who are driving innovation in biomedical research and public health. I'm Dr. Jay Bhattacharya, Director of the NIH. Joining me today is a distinguished leader in the field of addiction science and public health, Dr. Nora Volkow, Director of the National Institute of Drug Abuse here at the NIH, otherwise known affectionately as NIDA. Nora, thank you for coming. I have been looking forward to this podcast for quite a while, ever since we got to know each other very early on in my tenure. I had the absolute honor to be able to introduce you when you were given this award, this huge award by the folks at the RX Summit for your work at NIDA. I was hoping today to have a conversation about your work at the NIH and about drug abuse and its roots, the huge problem that the U.S. faces. And so thank you for coming.
Well, thanks very much for having me. And it was an honor to have you present my award. So thanks very much.
Okay, Nora, I wanted to start by just telling people about giving you opportunity to tell people, how did you get to be the head of the National Institute of Drug Abuse? What was your career path that led to this?
Well, I mean, honestly, I never thought of myself that I would be director of NIDA. I love data. I love being in the laboratory. I'm a psychiatrist, and I'm interested on understanding how the human brain works. And so at that time, when I finished my residency, I was using imaging technologies to see what drugs do to the brain. And you can ask, well, why drugs? And to me, drugs were fascinating because in people that become addicted, you lose the ability to self-regulate, and so you may make you may make a decision of doing something, but if you're addicted, that is terribly disrupted. So I wanted to understand what happens in the brain that loses that a person that loses that self-regulation.
So you're a psychiatrist. You were in your training, and you became fascinated with the brain.
I've always been fascinated on the brain since I was a little child. I wanted to understand how the brain works. I've been obsessed by it. And that's why I ended up in psychiatry. And when the imaging tools came that actually were being developed when I was in the residency, of course I jumped into them.
So like imaging tools like an MRI that can see which parts of your brain are lighting up when you think things, that kind of thing?
Yes, it's extraordinary. Think about it. The brain had never been accessible. So the way that we understood diseases like Parkinson's or strokes was the person died, you dissected the brain, and you saw the lesion. And in psychiatry, you don't have lesion diseases. You have network diseases. So they couldn't identify anything. And then we have imaging the tools like magnetic resonance imaging or MRI that allows you to see in vivo how your brain responds to stimuli, how you feel. And others like
so you think a thought, a different part of your brain lights up.
Yes. And what's interesting, what we've learned is that there's not such a thing as just one part. There are parts that consistently get activated when you see a visual stimuli. But what we've learned all along, there is a cascade because the brain is a network. So understanding how different areas of the brain interact with one another as we process information is what these technologies have opened up.
And okay, so now you mentioned addiction, right? So this is something that is obviously you've been fascinated about for it sounds like your entire career. What happens to the brain when someone takes an addictive drug? Let's say like cocaine or something like that. What happens to the brain? What changes? You called it a network. The brain is a vast network of neurons. How does the brain change?
Well, the brain, when you are intoxicated with a drug, and assume someone is given a drug, doesn't know what they have, and they take it for the first time, what the drug is going to do is activate the reward center, and that is stimulated by dopamine. So what drugs that are addictive do is they increase dopamine, and then they stimulate the reward pathways. The main reward pathway is located in the center of the brain, the nucleus accumbens, and it modulates the activity of multiple cortical regions. And this is why when you are experiencing a rewarding stimuli, you are much more receptive to everything else as it's happening. It modulates how you see your environment. And this is crucial for drugs because what they do when you stimulate the dopaminergic system is they plant a memory that actually occurs almost, if the stimuli is very, very rewarding, almost immediately. That would lead you, even though you may not be conscious of it, to associate that situation with a reward, with a pleasure. And that's what Pavlov called as conditioning, but now we can see inside the brain. So what you see is the formation of a memory that then will drive your behaviors automatically. So you pass by the chocolate machine that dispenses it, and the next day you pass and you desire a chocolate. And you are not hungry, but you desire the chocolate. And drugs are very, very effective on producing this conditioning. And so that with repeated administration, what you are seeing is strengthening of that conditioning, while there is a weakening of your ability to be conscious about what you are doing and self-regulated.
So like the things that would normally you say to yourself, well, if I eat this, I'm gonna get fat, or if I take this, bad things might happen to me. Those thoughts are no longer controlling. There's it's the pleasure center, the memory of previous pleasure that's controlling.
Well, it's basically controlling. You're trying to use your frontal cortex to self-regulate. No, don't do that because you'll gain weight, right? Or don't do this, take this drug because you'll end up in jail or you lose custody. But those systems basically start to actually weaken as the strength of the drive and motivation. So what drugs are doing is basically hijacking the main motivational drive circuit that we have in our brains. That makes us wake up in the morning and get excited about what we're going to be doing. That drives our actions.
Now, you were a medical resident. You finished your residency, and then you decided, all those new technologies coming out, so you can look at the brain, and of course, all these are like classical theories we're talking about addiction, right? And now you can actually look at it, much more scientifically than previously was possible with these new tools. How did your career path go?
Well, it basically became, it's almost like, there is a current, and like with knowledge, those findings come and then they get amplified. And what happened was, as new technologies and other investigators started to use imaging, we started to generate the whole picture of the changes that are happening in the brain of people that are addicted. And importantly, I could look at the brain image and tell you when someone was addicted or not. And to me, that was a very powerful argument to actually basically combat the myth that a person is addicted because they like the way that drugs make them feel, that this is a choice behavior. It showed it as a brain disease that actually can be linked with very specific changes in the brain. And that notion of addiction as a brain disease, of course, provided us the opportunity of bringing it into the healthcare and conceive a structure that allows to pay for its treatment. But it has generated a lot of criticisms too, because people say, yes, it's you call it addiction, but how can it be? It's a social construct. And I said, well, but our diseases are very much a product of our biology and the stimuli that we encounter. And in that respect,
it's both, right? Isn't it?
It's both. It's both.
Right. It's both something about the way we interact with the things that give us pleasure, but also the biochemistry of our brain, as well as the social milieu in which we make these decisions, if you can call them decisions, once you're addicted.
Absolutely, and it is. It is clear that addiction has a strong genetic component, and but I have in my family history of alcoholism. But, I have so many alternative reinforcers, and the environment has been so supportive that I'm not at risk. So this is the concept that we all have to understand when we navigate. How do we use this knowledge that identifies who is at risk and who is not at risk? What are the flexing points where we can intervene and prevent or treat? And so it is not a black and white.
Right. Yeah, it has to be both. Why don't we talk a little bit about some of the, I'll just say failures of the medical care system and healthcare system to really account for these kinds of ideas, and probably the most prominent of this. I know that you've seen this through your career, and I'd love to hear your thoughts about this. Is the opioid epidemic? That's probably the most prominent one in my mind for like a failure. Why talk about failures? I think failures. This is how we learn for the future. It's worth thinking about. When I was in medical school, I remember these new opioid drugs started coming out, and there was a lot of like talk about them not being particularly addictive. There was a lot of talk about, well, now that we have this tool, we should start treating pain as a vital sign, right? Normal vital signs, your heart rate, your breath, things like that. They wanted to add this as another vital sign, like how much pain are you in? But the idea that, well, if you're in a lot of pain, then you should be getting one of these now non-addictive painkillers, supposedly non-addictive painkillers. And I was struck by this as, if you enter medicine because you want to help people who are in pain, right? You want to help people who are with disease. There's a lot of like sort of goodwill around this. But of course, it turns out that the drugs were not non-addictive. Like they were actually quite addictive. What was your view? This was like in the 90s. This was happening, I think.
Yeah, no, and it's a perfect example about what are the negative consequences of the healthcare system having neglected addictions as a disease condition. You don't get trained. You didn't get trained then, and still many places, medical students don't get trained on their management. And so they couldn't recognize when they were prescribing these medications to their patients when they were becoming addicted. And it also is a beautiful example because it also exemplifies the negative influences that sometimes very influential publications can have in clinical practice. The practice that it was safe to prescribe opioid medications on patients suffering from pain, and that's the way I was taught in medical school, came about from a very, very small trial that was published in the New England Journal of Medicine that actually showed that people that were given an opioid with pain did not become addicted. And that is not correct. And now we know that there are people, no matter how much pain you have, you can become addicted to their opioid medication. That's one. The other issue, too, is because we also don't even know, we don't even train physicians, not just to say in the recognition of addiction. Many physicians don't even know how to recognize addiction from physical dependence. And so that can take us exactly to the extreme. So what is physical dependence? They give you one opioid or two opioids. I've been giving them in an accident. And I leave the hospital 2 days later feeling horrible because I decided I didn't want to have any more opioids. After 2 days, I was fed up with them. And immediately I had withdrawal. And if someone had seen me, they'll say that I was addicted and it was just physical dependence. And the problem there is that this is then interpreted to say the other extreme. 1 or 2 doses can make you addicted. So understanding what happened is crucial so that we avoid the mistakes that we've done. And I think that to me, the opioid crisis is a perfect historical example of how we need to learn how to avoid falling into a situation like that. And we seem to be not very attentive to it. We seem to forget very rapidly.
I mean, I think the thing there's a lot of striking things about that. Of course, as you say, there was sort of bad science at the bottom of it, right? There was a study, not really replicable study, that people just took at face value as true. There was the understandable desire to treat people's pain that people in medicine have. In the context of what we were just talking about previously, you have essentially a social system, medicine, that gives you permission to take this drug, right?
Correct. That gives you permission, but also that is being irresponsible, because what this overdose crisis also made us aware is that we have been neglecting pain. And severe pain is actually devastating, and people kill themselves. So, if you don't provide, if you've ever been in intense pain, you'll do anything in order to escape it. So if you don't have many alternatives, which we didn't, of course, first as a physician, second as a patient, you want to escape that state that is incredibly aversive.
I mean, there are things like morphine and other known addictive drugs for people who are in very, very severe pain. But this was a promise for a pill, essentially, to treat chronic pain that wasn't previously amenable to treatment without addiction, right? That was the promise. Or you could do like non-steroidal anti-inflammatory drugs like ibuprofen or something, or aspirin, which is but those are not particularly effective against very severe pain. Here's a drug that effective against severe pain, and now you have the warrant of the New England Journal of Medicine telling you that it's not addictive.
Correct, absolutely. And I think, and I do hope that we have learned that lesson too, that not let industry influence the reports that we have and the studies, because that unfortunate, it was a good researcher, wasn't it? It was just the
But
pressure.
you could be wrong, right? You could be wrong. And so, I mean, there's nothing nefarious necessarily, right? You have one report.
Yeah.
And the question is it true? Is not determined by, is it published in the New England Journal? And of course, there are these industry influences there, but also, do other researchers looking at the same thing find the same thing?
Well, part of the problem is that, and as you know this in the scientific community, if there is a theory and it is consolidated, it's very difficult to get publications that actually oppose it. And you have to break it. And I always think about it because I think sometimes our scientific community is very rigid. And there, you can come up with a model and your data, and there are reasons why that data may not necessarily apply to another patient population. It's not per se that it's wrong, it's that it is not generalizable. And yet we have the inability and the flexibility to actually question our models and change that based on the new information that's coming around. And I think that that's what happened with pain. It's clear that opioids have a role for severe pain. And there's nothing else for certain patients that except for opioids. But it's also clear that there are other medications that we started to underutilize because we got prejudiced that opioids were better. And opioids became to be prescribed for moderate or less severe pain, and patients felt safe. They thought that this was not going to make them addicted. Yeah. So that is, again, why we in the scientific field need to be able to provide data and to question.
Yeah, and of course, going back to patients, again, as you did, it had this effect of giving patients and people generally a warrant, and we saw a huge increase in addiction, starting in the 90s, very destructive impacts on people's lives, going off into the 2000 teens, and the consequence of that. We'll talk in just a few minutes about how NIDA, the National Institute of Drug Abuse that you lead, is helping to solve these problems, helping find solutions for these problems. But I want to just talk a bit about the numbers, right? So, roughly, I think in the 2000 teens, there were about 20,000 deaths a year, 15,000, some on that order, from these kinds of drug overdoses. Not just the prescription drugs, but also fentanyl, and other drugs that were illicit, not legal in the market.
They went to 50, 60 by 2019.
By 2019, 50,
but
60.
They started at the 10s and then 20s. And so you can see it's remarkable. You see the curves of the number of prescriptions going in parallel with the number of overdose deaths until 2010 or 2011, yeah, when the CDC came up with their guidelines and physicians started to be much more cautious on their prescriptions.
Right.
And then it just shot. Why? Because then we have made people addicted or physically dependent to the opioids, so they seek them out in the illegal mass market, and then we have the entry of fentanyl.
Right. And so now what did fentanyl do to this whole picture? Because you already had the opioid epidemic going on. Fentanyl is a cheap, it's used as part of surgery, right? It's given as a drug to help in, essentially with anesthesia and other, in order to make surgery you don't remember the painful thing when you go through surgery. That's normal. If anyone's had surgery, you probably have had some fentanyl.
Yeah, no, and it's a great medicine when used therapeutically, and for the anesthesiologists, it allows them to decrease the amount of anesthesia that they give you.
But it's a tiny molecule. It's in the sense that it's not hard to make it.
No, it's very easy.
Yeah.
I'm not a chemist, but my chemists in my lab say it's very easy, and so it is. And also as a result of that, it's easy. And the precursors at that time were readily available. So what it happened was you see the business models of the drug dealers, understanding that if they shifted their products into fentanyl, they would be making much more money. And so they started to first lace heroin with fentanyl, and then they expanded and started to lace cocaine and methamphetamine. And then they brought it up as illicitly manufactured pills that contained fentanyl, but that were sold as, say, for example, some of the analgesics like OxyContin or Vicodin, or some of the stimulant medications like Adderall. But because they were illicitly manufactured and you buy them in the black web, they were much less expensive. So people that needed pain medication would get exposed to these illicit drugs, or teenagers that wanted to get high with a prescription drug bought them in the illicit market. And we started to see overdoses in teenagers and overdoses in elderly people, which we had never seen. And that was a shift in the market.
This is in the 2010s, right? That's when this really
This started real. You start to see the rise in the 2020. I mean, the COVID pandemic left us very unprotected for the massive entry into all of these products. Fentanyl started to emerge around 2015, 2016. But by 2020, when all of the resources of our country were geared towards controlling the pandemic, there was much less attention of what was happening in our borders and the entry of these drugs. And they got disseminated everywhere, rural areas, urban areas, east, west, and in ways that were completely unexpected. I never would have thought how fast the fentanyl would get across the whole country.
I mean, we already had this substrate, if you will, a whole bunch of people that were already addicted. Their brains had been changed in ways that we just discussed just a little earlier, to be almost primed for this. And now you enter this drug that's relatively inexpensive to make. You have a pandemic which isolates people, right? The lockdowns keep you away from your friends, your family, maybe other things in your life. And
the stress. The stress of losing loved ones, and the stress of not knowing that you're going to get infected, and if you're going to be losing your house or your job. So, yes, and it's also another lesson for the COVID pandemic. You know, that first year of the COVID pandemic, from 2019 to 2020, the number of people that die from overdoses increased by 30%. And it does highlight, when we speak about a disease of the brain, how crucial social circumstances are, because isolation is one of the most negative things that you can do to an individual, to put them at risk of a wide variety of conditions, including addiction. So yes, the COVID pandemic just lit fire into a business that the dealers were moving forward that had already been seeded by the fact that we had made people dependent to opioids.
So you have supply side. I'm an economist. Please forgive me, Nora. You have the supply side. You have essentially the lockdowns and the pandemic create a situation where it's much easier to make and disseminate these drugs because there's less policing of it. And then you also have on the demand side a larger number of people isolated in pain, actually, in psychological pain often. Depression rates go up. Anxiety rates go up, especially in the young, but also in the old. And it's a perfect recipe for what we saw, which is there were, I think 100,000, before it was in the tens of thousands. By in 2020, for the first time in history, I think in the U.S., that we had 100,000 people die from these kinds of drug overdoses.
Yeah, and that was the shooting. I mean, all of these three elements that came into play that actually drove this steep rise. And then the second year, we saw another 15%. Yeah. And so it is, to me, again, this is another example, if we did not believe, of how important stress is in addiction, and how the stress gets amplified when we have it at the national level, right? It's not just something that's happening to me, it's happening to everyone, and multiple systems get disrupted. And all of that promoted the isolation. And so we also see, for example, during that period, actually just not exactly at that period, but a little bit later, that rise in suicide. So these events are very consequential to our well-being.
Actually, can we explore that for just a second? Because that actually puzzled me a little bit in 2020. because I read there was a CDC report in June of, I think, of 2020. Is a standard survey that they give every year. But that year they gave the survey and they asked questions like, have you seriously considered suicide in the previous month? Suicidality, suicide attempts, and so on. There was a sharp increase in suicidality. Like I think 1 in 4 young adults in June of 2020 had seriously considered suicide. But there were fewer completed suicides, if I'm understanding correctly, in 2020. Weirdly, there was actually, I think, an increase in motor vehicle deaths, even though motor vehicle traffic went down. So it was kind of a curious thing, like how, because we've been talking about addiction and about loneliness, but it played itself out with suicidality, drug overdose deaths, but fewer completed suicides.
It's interesting because that had been studied in the past, and researchers have commented that when there has been an emergency situation, that during the first stage of that emergency situation, suicides actually go down. It's afterwards that you see the rise.
Which is what happened, right?
Which is the of course people try to speculate what drives this, but I think that one plausible cause for this phenomena is that when we're in all of it together, there is this sense of we are part of something and people care. Once that structure gets removed and you're still facing that stress, but you don't have the support of the others, then that's where it hits you and you start to actually have the higher risk of suicide. This is one of, again, the hypotheses that has been brought up for that phenomena, that it delays. With drugs, it's different. With drugs, you see it immediately because if you're very, very anxious, taking a drug can temporarily decrease that anxiety. It makes it worse with repeated administration, but it's sort of like an auto-medication trying to escape.
Right. Okay, so, those numbers stay very high for years. 2020, 2021, 2022, 2023, still in excess of 100,000 drug overdose deaths a year. It's only this past year, in 2024, we've seen some modest improvement.
I call it very significant improvement because I have been actually seeing very, very little. And people would tweak 1 month and says 1% decrease. I says that's noise in your data. But what is remarkable in 2024, and that's why I call it significant, we see a 27% reduction, 27.
Yeah.
And that is, you see it consistently. Now, one of the questions in my brain had been the concept of, we discussed how the COVID pandemic had exacerbated and this steep rise of 45% the first 2 years. So I was thinking, is it that we are going back to the levels that we have because now that the COVID pandemic has been resolved? But if you look at the data, we are below the numbers of the 2019. So it's not just that we are improving over what it was before the pre-pandemic. So
that's actually surprising, Nora, because the numbers I saw, we're still in 2024 something like 80,000 deaths.
Yes.
Which was above what I thought.
There were 110 on 2022.
In 2020, right? That's a big decrease from 2023, but still not as good as. And not that 2019 was much to write home about, but better than 2019. We're still not back to pre-pandemic levels as yet, right?
I think that we are. I've been looking at it and actually back and forth and the last numbers, because initially I thought that we were. I went back. I look at it every month and it was just in the border. It sort of deceives your eye because I wanted to believe that. But now looking actually at the numbers of the preliminary data, it looks like it may be below. That was my understanding. But again, this is sometimes wishful thinking.
Well, it's still, even before the pandemic, it was too high. Let's just say.
Oh yeah, no, it's very, very high still.
Okay, so I want to finish out by talking about NIDA. The purpose of NIDA is to help solve this problem. And we've made some great advances. And I wanted to give you an opportunity to talk about some of the things that NIDA has been involved, like Naloxone, a whole bunch of other things I think that made things better.
Yeah, no, and thanks for asking that question, because it is ultimately, we are a science agency. We provide research for people to do work that can help us address the problems of drugs, ideally prevent them, and treat them and understand them in terms of all of their complexities. And in this case, for the overdose crisis, we were fortunate actually because we got funding through the HEAL initiative to actually be able to expand our research to address the deaths from overdoses. And
HEAL initiative, what is that? What is that?
That is an initiative that actually, again, aims to control the problem of addiction in our country, addressing at the same time the crucial component that improperly treat pain has in contributing to it. So it advances research on pain alternatives for medications that are not addictive. And on the other one, it provides us, the way that I view it is, we have a lot of knowledge, but right now we don't have the luxury of time. So in my brain, we needed to do interventions where we knew already that the evidence showed benefit, but we were not implementing it. So I said, let's work on implementation projects that bring the screening and treatment of addiction, basically opioid addiction was the key priority, but not the only one, into the healthcare system. And you say, obviously, it's not obvious. It was not done. And the other big system that we tackled was the justice setting, because a very significant number of people that die from overdoses have come through, rotated to a jail prison or to another form of justice intervention. And then the third one, we went to the communities. So we launched these gigantic projects to address implementation of therapeutics for opioid use disorder or opioid addiction, and for preventing overdoses, and for educating also clinicians and their patients, while at the same time accelerating our pipeline for therapeutics. So through NIDA funding, we were able to get nasal naloxone or Narcan.
So excellent, naloxone. Many people probably don't know. Many people are probably listening. This is a very sophisticated audience, but some people might not know. What is naloxone? Why is it important?
Well, naloxone is a drug that basically blocks the opioid receptors, and the opioid receptors are the drugs that heroin, morphine, fentanyl bind to. And we have these opioid receptors in our respiratory centers and also in the reward center. That's why they are addictive. But in the respiratory center, what these opioids do is they inhibit your automatic respiration. So that's
breathing.
Why people die.
Yeah.
You stop breathing.
Yeah.
And what happens? You lose consciousness. And if someone does not administer you naloxone gets into the brain immediately, it blocks that receptor, and you save a life. It's almost magical if you give it in time at the correct dose.
Right. So someone overdoses, they stop breathing. The signal that your brain normally sends to your diaphragm and to take a breath is depressed, gone. Right. And what naloxone does is it goes in, blocks the receptor where the opioid normally hits. And then that signal then goes back. It turns back on. You start breathing again.
It removes the brake on the respiratory center. It's not a good thing to break your respiration.
No, it's really bad. Breathing is good for you.
The other beauty about naloxone is as safe as it gets. If I give you naloxone, you won't feel anything. So if someone is out there, lost consciousness, and they don't have an opioid overdose, you are not going to harm them. But if they do have an opioid overdose, you will save their lives.
Right. So it's a really important drug for managing drug overdoses, and making sure that first responders have access to it, making sure that people where there's lots of possibilities of overdoses, like in even in jails and other places, having access to it. That's important then.
Absolutely. And in fact, one of the things that has been happening in our country is that naloxone now is available in many schools, because teenagers that get these illicitly manufactured prescriptions have been dying in the schools.
So I think that's a really important thing, to make sure that when the overdose happens, we can address it. But what are we doing to change our society, our systems, so that we don't have so many people attracted to these drug overdoses, to drugs that can lead to overdoses?
Well, I would say, in looking at all of what we know, and of course, lots of researchers, scientists have spoken about it, and there are the genetic vulnerabilities, but beyond the genetic vulnerability, because that is the same, actually, before and after all of these overdose crises that we're living, what we have is the social constructs that are necessary for us to provide us with resilience. And so we know for prevention study that the most powerful intervention that we have, the most powerful actually structure in our favor is the family. And what happens is that if you have a supportive family and parents that care and the opportunity of this child to develop and has activities and it is a good school environment, that provides them resilience. I think that I am an example of that. I may have the genetics, but I didn't become addicted. But then there are all of these children that, for example, grow up in families of one parent, and the parent has had to have 2 or 3 jobs, and no one pays attention to this. They are neglected. We know that, for example, childhood adverse experiences, physical, sexual abuse, neglect, actually significantly increase the rising on the risk for addiction. So I think that what we need to address ourselves as a society is what do we do to strengthen those social networks that are so necessary to prevent it. And these social networks, though, are also crucial in order to achieve recovery. So you treat someone, you want them to reinsert themselves in a social structure that will be supportive for them, because otherwise they will relapse. Yeah. And if they relapse, they again are higher risk of overdoses. So I view this whole process as a cascade of care where we think both on the prevention component, on the treatment, and ultimately in the recovery, and where social networks, family, healthcare systems, and communities play extremely important roles for us to succeed.
Like social connectedness, deep connections with family, with friends, with a community that's supportive. Yeah. That sounds really good for lots of reasons, not just for avoiding drug abuse.
Absolutely. For health in general, what I call meaningful social connections, the issue is that a lot of people that may have them give it for granted. And the reality is that not everyone has them.
I'd love to hear, as we close, before we close, I'd love to hear thoughts on one controversial policy, I think. Maybe it's not controversial, I'm not sure, but it's in my mind somewhat controversial. Needle exchange programs. Right, so someone's addicted. Very often they're homeless, or they're in environments where they have access to some kinds of care, and the idea is of harm reduction. Right, so often shared needles are ways that diseases like HIV, hepatitis C, and other diseases might spread. And so the idea is, if you provide needles for people who are drug abused and drug abusers, you'll reduce the rate of spread of those diseases. And at the same time, you potentially make it easier to stay addicted, right?
But what is curious, Jay, is multiple studies have shown independent that basically syringe exchange programs prevent infection from HIV and HCV.
Yes.
And the studies also show that they do not in any way promote more addictive behaviors. The issue that people don't understand is when you are addicted, these considerations that says, okay, I'm not going to inject unless I have a safe syringe, does not play a role. And in fact, one of the concerns is people will inject a drug even if they know that the material is contaminated, even if they know that that substance could be lethal, because the desire is so strong. And I had once a patient that basically was commenting that, I always try to get a sense about why they do these behaviors that are rationally don't make sense. And he says, Doc, just think about what it is when you are underwater and you want to breathe and you want to breathe. There's a point that you'll do anything to jump out so you can get oxygen. He says that's the intensity of the drive for taking a drug. So no, having a clean syringe or not a clean syringe doesn't make a difference. And the same argument has been used by many and says, well, why do you give them naloxone? They are going to overdose again. And I said, because if you save their lives, you are giving them the opportunity to eventually go into treatment and recover. Otherwise, they'll die. And then there are many reasons. So it is that whole notion. Sometimes I think we become very categorical that we have to either have complete abstinence or nothing. Is harming our patients. And in the substance abuse treatment field, it has led to really very poor outcomes because, for example, a practice that fortunately is much less frequent now than it was in the past, but still being done, You go to treatment, you are sick, you have an addiction, right? And you relapse. They throw you out of treatment. And then the risk of that person to die from overdoses is extremely high. And I have so many parents come to me because their child died that way. And it just hurts my brain and my heart and everything. And says, my God, we don't do that for any other condition. If someone relapses with cancer, with hypertension, we basically reevaluate and restart the treatment, modified based on the circumstances.
Yeah, that makes sense. I mean, so ultimately, as we close this podcast, we can come back to the theme we started with, right? This is a condition both of the brain, the understanding how the brain reacts to these potent potent agents, and also our society, that if it's structured right can help heal it, and if it's structured wrong can help push it forward. But NIDA is working really hard to make sure we have excellent science to address the problem.
Correct, and that we give alternatives, both in terms of prevention that will protect people, but also alternatives for treatment, and importantly, also models of care that will enable recovery. And that requires that we work with the agencies, because I can come up with a model of evidence-based that no one reimburses, and then it's not going to happen.
Well, Nora, thank you for joining me at the director's desk. To our listeners, thank you for tuning in. Drop your comments in the chat as to what subjects we should talk about next time. And thank you for listening. Please be sure to hit that like and subscribe button on your preferred podcast platforms. Until next time, I'm Dr. J. Bhattacharya, and this has been Director's Desk.